Let's get started in earnest and actually go through this. We still have plenty of time to get through all my slides and hopefully have some time for question and answer. So the 2019 novel coronavirus disease has been characterized as COVID-19 by the World Health Organization. So that's why you keep hearing COVID-19. It actually was identified December 31st of 2019. At least that's when the Chinese government announced that they had an outbreak. And so that's why the 19 is on there, even though it was the last day of the year. But the actual coronavirus is a beta coronavirus, and it's been designated SARS-CoV-2 by World Health Organization. So if you're talking about the virus, it's SARS-CoV-2. If you're talking about the disease, it's COVID-19. And the 2019 novel coronavirus is similar to SARS and MERS, same kind of genetic stock, but some variations. But it all starts with the same kind of symptoms, with fever, respiratory symptoms, cough, difficulty breathing, things like you'd find with flu and colds and things like that. We have learned over the last few weeks, I mean, this really only started getting characterized mid-January, that the median incubation period is about 5.1 days, but the range is anywhere from 2 to 14 days, even a little bit longer than that, as you'll see. So about 97.5% of people are going to get symptoms within about 11 and a half days. So the vast majority of people will get symptoms in that period of time, but about 1% are going to develop symptoms after 14 days. So cases are likely infectious 1 to 2 days before symptom onset. So basically, as soon as they're infected, they might also be infectious to other people. Fecal transmission is possible, but it's really unknown right now. We know that we can isolate the virus in feces. We don't know if it is really a viable mechanism to transmit that. So we're treating it like it is, so that people need to wear those kind of precautions when they're dealing with patients, and they need to wash their hands diligently, even if they're over the illness, if they're a confirmed case, so that they don't risk spreading to other people. But asymptomatic transmission is really clear. We're definitely seeing that. And the duration of that infectiousness is really not known, but we do think cases are most likely to be infectious while they're symptomatic. So let's talk about the virulence of COVID-19. It's more virulent for elderly and those with underlying health issues. The overall mortality rate is probably something around 2 to 3.5%. In Italy right now, it's at 7.9%. That's as of yesterday. It's very high. China is about 4%. South Korea, on the other hand, is a little less than 1%. So it just depends on probably the medical characteristics of the patients and the availability of clinical care that might make a difference there. But to compare to some other illnesses, the 1918 Spanish flu, the big pandemic influenza, the mortality estimates were 2.5 to 11%. SARS is about 10 to 15%, so a similar coronavirus is a little bit higher, but MERS is even higher. It's 30 to 35%. And then seasonal flu mortality rate in comparison is about 0.1%. So if we're saying that COVID-19 is like 2.5%, that would be quite a bit higher than seasonal flu. Our recent hepatitis A outbreak that we just had, that was about 1% to 3%. In Kentucky, we were around 1%. Some other states were up to 3%. And of course, there's things like Ebola that are way up in the range of 25 to 90% mortality. We're not going to be there with COVID-19, thankfully. I put this map in from January 24th of 2020. This is where things were just a month and a half ago. And you can see almost all the cases are in Asia. There's one case in the United States, but Singapore, Thailand, Vietnam, China, Korea, and Japan were really where we were seeing cases. Now compare that to, this is, it should say March 18th. I didn't change the date on there. That's from yesterday, that map is. I did change it on the side. As of 12 p.m. March 18th, 2020, 160 countries with cases. A pandemic was declared by World Health Organization on the 11th of March, and we've seen just dramatic worldwide spread, and you're going to see that in the numbers. So the current international situation as of 10 a.m. yesterday morning, 191,127 confirmed cases, 81,000 of those are in China. That's down to 42.4% of the total. Until a couple weeks ago, China had the vast majority of cases, but now their incidence is going down dramatically, and it's gone up dramatically in many other countries. So there's about 110,000 cases outside of China, and that's a tenfold increase in the last 18 days. 47 countries there's 47 countries in the world that have more than 100 cases. That's doubled in the last 6 days. And there's about 14 countries with more than 1,000 cases, and that's almost doubled in the last 6 days. So you're seeing this dramatic increase in a lot of countries. 7,800 deaths, that's about a 4.1% mortality rate overall. 41% of those are in China, but they've only had 13 deaths in the last day, where 4,500 have been outside of China, and that was 773 new deaths in the last day. So you can see the dramatic switch over where it was almost all in China. Now it's almost all in the rest of the world. An interesting side note to this is there are a lot of cruise ships that have been affected, and I think that's partly because of the environment of a cruise ship, where it's a closed environment and people can transmit to each other. So that's a difficult situation. And in one cruise ship alone, the Diamond Princess, there were 712 cases identified so far. Now, those people are off the ship now, but cases still are arising just from people who were infected while they were there. The problem is there's a whole bunch of cruise ships that are involved. There's at least 4 Nile cruise ships, and there's other cruise ships in the Pacific and in the Caribbean. So there's been a number of ships that have had cases, and that's been a really difficult situation. So in the U.S., our first case was identified in Washington State on January 22. Now there's 7,038 cases in 54 states and territories, including Washington, D.C. There's been about 269 cases that we can show are travel-related, 276 that we know are person-to-person spread, but there's another 6,493 that we haven't even been able to identify how they were affected, just because it's come on so quickly. It's hard to get the investigations done with all of these people. We're this time at 97 deaths. I'm sure we're over 100 by this point in time when I'm doing this presentation, because that was as of yesterday. But the primary burden has been in 3 states that really have huge traveler populations. That's Washington State, New York, and California. You can see New York's got 2,600 cases. They had very few a couple weeks ago. Now they're over 2,000. So here's an epi curve I just pulled off of CDC's website. This is the COVID-19 cases in the United States by date of illness onset. And of course, that gray area at the right-hand side is showing that those cases aren't nearly reported yet. So it's not the curve going down. It's just we haven't filled it in yet, because we'll get cases reported as time goes on. This does not include the cases that came in from Wuhan, China, or from the other cases that were brought back into the United States, repatriated here. So there's a few not counted in there. You can see the kind of dramatic increase here in the U.S. since about the middle of February. This is a map showing the states by incidence. So you can see Washington and California are pretty high. New York's the highest, and all the states have cases now. West Virginia was the last state to announce a case, and that was just a couple of days ago. So let's talk about what's happened here in Kentucky. So we began traveler monitoring in early February, where we were tracking people who came into Kentucky and monitoring them for symptoms, making sure that they didn't infect other people. At that time, we could only test people with the CDC person under investigation, the PUI definition. And all tests had to go to CDC to be done. We didn't have any testing capability here in the state. We tested our first patients on Friday, February 21, and then the next Friday, February 28th, and both of those turned out to be negative. Both of them had international travel and had symptoms, and so we went ahead and tested them. The PUI definition changed on March 4th, so CDC made a broader definition to include unexplained acute respiratory distress syndrome, ARDS, and pneumonia if the patient was hospitalized. So if they had tested for everything else in the world, flu and strep and everything they could think of, and everything was negative, and this person had unexplained pneumonia, then they would go ahead and approve that for testing. However, that's about when we started getting testing capability here in Kentucky too, and so we were not approving everything just because we had limited numbers of tests available. So Friday, March 6th, that's when we got our first test positive in Kentucky. And then on March 8th, just 2 days later, we had 3 more, and outside laboratories started to come online on March 12th. And so yesterday, Wednesday, March 18th, we had 33 positive patients. I can tell you there's some more already today, so we're going to be higher than that today. But initially, we had a cluster in Harrison County. You may have heard about that. That's a small county kind of north of Lexington, northeast. And they had, it turns out, an exposure to someone who had gone to California, which we didn't know until a couple days ago, had gone to California just about the exact same time California identified its first cases in LA, and this person was in LA. So we think that's the connection that brought it into Kentucky initially. We've had several others since then. I'll talk about those later. But that person was symptomatic after returning, did not get tested. We didn't hear about that one because that wasn't suspected in this person's case, so they were not tested because at that time we were really mostly looking at international cases, so providers weren't reporting people who had travel in the U.S. and was sick, got better, but a number of other people we think that had close association with this person got infected, including the very first case who was hospitalized in Lexington. This person was only tested because later on, the health department director in Harrison County, with some latitude to do some additional testing, tested a couple of asymptomatic people, and this was one of them because he had close contacts with several of the cases. So they tested him, and lo and behold, he turned out positive. So we think that was what happened. Was that person brought it back from LA, and then a number of people were infected through different venues, through work setting and religious setting and things like that. So that's the first cluster, and that right now accounts for at least 9 of our cases, is all associated with that one cluster. So let me tell you about our testing characteristics up to date. So right now, we've had 314 tests approved at the state laboratory. That's just about the extent of what we can test. We're hoping to get more supplies in today, and then maybe they've arrived, I don't know, but we were running short on supplies because there's only so much that CDC distributed to the state. So out of that, we've had 25 positives, 248 negatives, and there's 42 that are still in process. Either they're being run or we haven't received the specimens yet, but that's how many have been approved, 314. About 584 tests have been done in other labs around Kentucky, including the U of L lab, and we've gotten 8 positives out of that and 137 negatives. Actually, it's more negatives than that, but I think there's still some pending as well. So we've had a total of 33 positive out of at least 898, so almost 900 people have been tested. We've gotten 33 positives. That's really interesting because, initially we were approving tests of people who we thought were likely candidates to be a possible exposure to COVID-19, and you can see the test positivity rate for the state is pretty good, 25 out of 314. But when it's expanded out to other labs, then they're testing a lot of other folks that maybe have an upper respiratory illness and maybe haven't been tested for other things or maybe don't have an exposure. So you see the positivity rates much lower, 8 out of 584 for these outside labs. And another interesting thing that's happening right now, which is really a problem, is there's a whole bunch of pop-up labs joining the fray. So FDA approved an emergency use authorization, an EUA, so that any lab could test for COVID-19. They just had to show that they could test it accurately. So any lab can start testing as long as they get 5 positives and 5 negatives validated by another lab who is already validated. The problem with that is FDA said they can report results as presumptive until they're validated. So just in the last 2 days, we started to get reports from labs we've never heard of, just small labs here and there. And in fact, got a call from Minnesota about another lab that got from another place that got a positive from a Kentucky lab that they had not heard of. And so we don't have any visibility on these labs, and they're not typical public health kind of labs that report reportable diseases. So they don't really know the process that they're required by law to report and things like that. So this is an interesting emerging issue right now at this point, is how do we deal with all these pop-up labs that are testing and offering their services to clinicians across the state, because tests are short, so clinicians are looking for options, and then, yeah, we don't get that information at the state, so that makes it hard to know what's going on all the time. So let's talk about the patients that we do have identified, those 33. So 55% are female. The age average is 56, the median is 58, and the range is from 26 to 88. Most of our patients are older. We have a 26 and a 27 and a 31-year-old, but then everybody else, I think, is quite a bit higher than that, 50s and above. Several had air travel domestically and 2 internationally. We've had a couple of people who are frequent flyers. They went all over the United States in the days before they got sick, and one of them went all over the United States and to Mexico while they were sick, so that was a problem. We've had 2 that traveled internationally outside of the guy that went to Mexico when he was already sick, but we've had 1 from England and 1 from Switzerland. It looks like they were exposed in those countries and brought it back. Domestic travel is a problem right now. We've got 4 people positive who took ski trips in Colorado, and I don't know if any of you have seen in the news, but basically they've recommended that anyone who was in a resort in Colorado, a ski resort, needs to be quarantined because they've had a massive outbreak in the ski resorts there. A lot of our people in Kentucky are person-to-person travel, many person-to-person communication transmission. So, and we only have 1 healthcare worker identified. We've tested a lot of healthcare workers. Only so far 1 has been identified as a positive from transmission from a patient. So I want to talk about that CDC guidance, formerly their person under investigation guidance. So they had this real specific PUI criteria. You had to have come from anywhere in China or from Wuhan or Hubei province was a higher risk, and then they added on Iran And then they started talking about other countries at risk, but didn't add them on to the actual PUI guidance. And then they opened it up and kind of changed it, and they added the part about if you had unexplained ARDS or pneumonia and were hospitalized. And then they went further and opened it up. And the last PUI guidance, which is still active, is really up to clinician judgment. So does the patient have signs and symptoms compatible with COVID-19? Most of those patients are going to have fever or symptoms of acute respiratory illness, but their priority includes hospitalized patients who have signs and symptoms, or those at higher risk for poor outcomes like older adults or immunocompromised, other health conditions like diabetes or heart disease, immunosuppressive medications, things like that, or any person who has close contact with a suspect or laboratory confirmed COVID-19 patient, or who had a history of travel from affected geographic areas within 14 days of symptom onset. So basically they're leaving it up to clinicians to kind of make that assessment. What we found is clinicians aren't really confident making that assessment without talking with somebody in public health. So they can get tests other places, although they're fairly delayed now. I'll talk about that in a minute. But if they want to get tested by the state, they do have to have approval through the state Epi program to get approved to test. But otherwise, they can test. But still, lots of clinicians are calling us just to consult with us to decide whether they should test someone or not. So, and I'll talk about how many calls we're getting in a minute here. But we're getting a lot of folks calling just to ask what they should be doing, because that guidance isn't that clear. To continue that, the epidemiologic factors that might help guide that decision, of course, are if there's community transmission in the area, that may contribute to decisions. But clinicians are really encouraged to test for other causes of respiratory illness first, like flu and strep and those kind of things. There is an argument, I've said this on our clinician webinars, that if you don't test, you won't find. So we've been criticized for not testing enough. We've had to do that by default just because we don't have enough tests to test everybody. But you don't need to test everybody that just has an upper respiratory illness. That's the fear that's happened, is now everyone who gets the sniffles. I just had a cold last week and I stayed home from work 2 days. I can tell you it wasn't COVID-19 and I didn't get tested for it. But a lot of people now worry they've got COVID-19 just because they've got a cold or possibly flu. And flu is still circulating right now. We've had 80-some thousand cases and I think 85 deaths, maybe more now this season in Kentucky. So we don't need to test everybody, but we want to test people who could show that it's in a new area or it's in a high-risk population, things like that. So right now we're kind of encouraging, if you're mildly ill, to stay home and contact your healthcare provider if you need further guidance. Patients with severe symptoms, of course, they should seek care immediately. And a patient should be assessed early in their course of illness, or even mild illness, if they do have high risk factors, like being an older patient or somebody with underlying medical conditions, or if they're immunocompromised, something like that. So our testing priorities in Kentucky are, since the COVID-19 testing is becoming available in clinical laboratories, and that's going to allow clinicians to test a wider group of symptomatic patients, we're really emphasizing that at the Kentucky Department for Public Health, we're focused on cases with public health significance. So they got to have the symptoms usually. I mean, so we have tested a couple of asymptomatic people in really high-risk situations, but should have the symptoms. We're prioritizing people in critical settings like healthcare workers, first responders, people in jails, things like that, long-term care facilities particularly, because that's a very high-risk population if it gets in there. Those with critical illness, that all of their pathogens have been ruled out, or they've got a really unusual clinical course, or they've got clear exposure reported. And once again, those not ill enough to be hospitalized, they can be referred to a commercial laboratory. They can stay home and get tested by their provider through a commercial laboratory. But we don't recommend testing asymptomatic patients, because the results are not going to really help you in most cases, because the person could be infected and yet not viremic. We just had a case like that where the person tested 7 days ago and they were negative. Their clinical course worsened and they were tested again and they came out positive. Now that could have been a false negative before, but it could also have been that they just weren't viremic enough to register yet on the test. So we don't recommend testing asymptomatic people, because it's not really an assurance that they're not infected. So to identify and assess COVID-19 patients, we're really urging healthcare providers to ask every patient about their travel and their exposure history. So if there's travel to countries with community spread, the CDC website has a list of those. Travel to domestically to high-risk areas like Washington State or LA or places like that. If you have contact with a confirmed case, of course, we've got lots of healthcare workers here that get exposed to any one patient. So if that patient's positive for COVID-19, that could be a huge risk factor. Does the patient have symptoms of respiratory illness? Do they have a fever? And if yes to exposure and symptoms, then we'll consider testing. If it's in the community, we should consider testing those with appropriate symptoms if it's warranted by clinical judgment. So at some point, we expect COVID-19 to be spreading across the whole state. And so just testing everybody for it is not going to really do us a lot of good when we know it's already there. But we do want to know how much the burden is. So once the commercial labs get up, that should be very easy to do that. So reporting cases, this is really important, and we really stress this with clinicians. So any patient with a positive COVID-19 diagnostic test is immediately reportable to the Kentucky Department of Public Health. There's state regulations that back that up. It's a newly recognized infectious agent, and so it kind of falls under emerging pathogen also, so it falls into those categories. Healthcare providers that are notified of a lab positive, they're supposed to call us and then also send in an EPID 200 case report form to our secure fax. And we do this in order to contain and slow the spread of COVID-19. We have to have that information quickly on initial cases if we want to implement our control measures. If we don't know where cases are arising and we don't know who they are, we can't get them isolated, we can't quarantine contacts and things like that. We've had a lot of difficulties getting results to the providers or the patients or the local health departments just because it's coming so fast. It's hard for us to keep up with the kind of onslaught of the cases that are the testing that's happening. So you may say it's only 33 cases, but for each one of those, we've got to identify the provider and the local health department. There's usually calls involving health care if the person was hospitalized. So it takes a lot of work for each single positive case right now. So our strategies, this is really kind of the important part from the public health end of it is the first strategy is containment. You want to try and keep the disease out of your population. So the way you do that is you quarantine those who have been exposed, if they've had travel to those countries with sustained community spread, exposure to a known case, et cetera. And then early identification of and isolation of cases. So people who are a confirmed case, keep them from infecting other people and keep the healthcare contacts low and protected and try and keep transmission from happening in that way. So that's where we are with any place that hasn't had many cases. So that's most of Kentucky. They haven't had many cases. I think today, if you watch the reports, you'll find out there's several more counties that are going to be added, and it is starting to spread in different parts of Kentucky where we haven't seen it yet. But at this point, it's not everywhere. So the community mitigation strategies are really the big thing, because those are the kind of things that would stop any infectious agent like flu or cold or things like that. And that's the kind of stuff the governor is really emphasizing. So a focus on overarching prevention strategy. There's kind of two realms of those, personal and then community. So for personal, we're really pushing the social distancing, hand washing, covering your coughs and sneezes, especially staying home when you're sick. I was sick this week, like I mentioned before, and it was a mild illness. I would have normally come to work during that time. I just stayed home because I'm trying to protect anyone else from exposure to something that could get them out of work for 14 days, even if it's not COVID-19, because we're all paranoid about respiratory illnesses. But then there's these huge community strategies the governor has implemented. So shutting down the restaurants, in-house dining, schools closing, shutting down government face-to-face business, urging non-essential businesses to shut down for a period of time. These are all designed to slow the transmission and make it more manageable, and I'll talk about that in a minute here. But this is going to be implemented in phases as the transmission picture changes. So the community mitigation stuff should be going on all across the state because we're encouraging that. But the isolation, quarantine, contact tracing, all that kind of stuff is really going to start in those areas that haven't seen any cases, try and keep it out of those communities. But once it's widespread, if that happens, then we'll just be strictly working on community mitigation strategies because there's simply not enough workforce to contact trace everybody who's got an upper respiratory illness and quarantine all the contacts and things like that. It'll be unmanageable at some point in most areas. So here's the reason, and I'm sure a lot of you have seen this before, this graph from the St. Louis, Philadelphia example from pandemic flu. So our goal is to slow transmission, and this is really important because it reduces the burden on hospitals, and that in turn will reduce the mortality rate. So isolation and quarantine, like I said, are our frontline prevention measures, and then social distancing measures should be implemented early. Personal social distancing messages and public interventions like I just talked about. And if you look at the chart, the yellow curve, it's Philadelphia, where it says Philadelphia. And so they identified their first case on September 27th, and they didn't implement social distancing interventions until October 3rd. And you see how their cases spiked very high. But what that does is it overwhelms the medical system, and hospitals can't handle it. You've got people that can't have ventilators that need them and things like that, so your mortality rate goes up. Whereas if you can keep the curve lower, you kind of flatten the curve, then you can extend it, but have have the capacity to deal with it on an ongoing basis. So that's really the strategy that we're following right now, is to try and reduce that transmission rate so that we can reduce the burden on healthcare facilities and keep it manageable. So quarantine and isolation, we still are asking people with high or medium risk exposure to self-quarantine for 14 days after their last exposure. And if symptoms develop, they should self-isolate, contact public health, and if they need to get assessed medically, to see their healthcare provider, but to call in advance so they don't expose people in the healthcare facility. People at low risk should self-monitor for 14 days. We're not asking anyone at this point to report temperatures. We did that initially, trying to keep it out of Kentucky, but now that it's here, we're just asking people to self-monitor and do those same things. They're not required to quarantine if they're low risk, like the high and medium risk, but if they're exposed in a low risk setting, then they can just monitor for 14 days, go about their normal activities, and then report to us if they have symptoms, and then get assessed by a healthcare provider, just like in the other folks. I just wanted to throw these in here. So high risk versus medium versus low versus no significant risk, it really varies, and it's situation by situation. So we assess those individually. So healthcare workers particularly at risk. Close contacts in a non-healthcare setting is another one. Travel out from Hubei province, China, is still considered risk, although I think that's going to come off soon. But I'll give you an example. One of the cases in Washington State, it appears, was exposed by a person who came from China. They were not considered high risk, but they were asked to quarantine for 14 days. And then they felt that they needed to get their nails done. And they went out and had their nails done, and then the nail operator got infected. And then that's what led to a number of cases in Washington State. So just that close contact for like an hour across the table getting your nails done was what exposed somebody else, and then introduced that in a widespread population. So we really take these seriously. If you're high or medium risk, you really should stay away from other people as much as possible. Don't go into public settings or take public transportation or things like that. If you're low risk, monitor your symptoms, make sure you don't get anything. Let us know if you do, but go about daily activities. No identifiable risk. We have lots of those people call in and say, I was in the line at Popeyes next to somebody else who said they just came from China, and they're not sick, but I just wonder what I need to do. And in most cases, that's no identifiable risk. And we go on with life. So one of the issues we're going to come up with is how do we triage patients when there's widespread transmission. So for healthcare facilities, this is particularly important. They should be triaged when they come in if they have respiratory illness, if they have travel exposures, if they've had contact with confirmed cases. Those people should be separated, have a mask on if they're coughing or anything like that, so that we can assess them properly without putting anyone else at risk. If we suspect that that's a possibility, COVID-19, they should have that mask on and assess them clinically using the proper PPE, and then collect specimens safely. If you're doing an NP or an OP swab, that could be an aerosol generating procedure, which puts the healthcare workers at risk. It says audio has dropped. Can somebody let me know if you can hear audio now? We're still on according to this. 5 minutes ago. Can somebody let me know if you can hear me now? Okay, so somebody's dropped audio, but I guess everyone else can hear. Okay, so once again, collect the specimen safely. With if the person's coughing or stuff, that person has got to be on. Thank you, I got the messages so that we can hear now. That person's got to have the proper PPE on so that they don't get exposed when they're taking those specimens. There are some alternative collection strategies people are talking about, like triaging people outside of a facility rather than having to come inside. My parents live in Washington State, but they're on the east side where there's not any cases, but they said their hospital has a triage tent outside. So when you go to the hospital, you get assessed first if you got temperature or symptoms or anything before they let you come in the hospital. PPE is personal protective equipment. Thank you for somebody asked that. Personal protective equipment is the mask, the shield, gown, and gloves that people would wear. So another possible specimen collection is drive-by specimen collection, or drive-through, or drive-up. There's different terminologies. That's where we would collect the specimens from the person in their car, which has limited exposure to anybody else. It's just the healthcare worker has to be properly gowned and gloved and have their right stuff on. I'm going to talk about that in just a second. Oh, now I can't switch slides, Jody. What do I need to do here? Okay, so we've been really having to adapt to a changing situation this whole time. So lab specimen collection and submission, we're running out of lab supplies. That's a national problem. There's 3 areas where you can really be in trouble. One is if you, I don't know, I'm getting text messages, but I think we're okay. If there's the collection materials like swabs and tubes to send stuff in and the medium to send them in, that's one area. The extraction kits that they use at the lab to get the specimens into the testing machinery, and then the reagents that are used for testing. And all 3 of those can be short. Originally, the reagents were short. Now they're fine, but our collection kits, the swabs, are getting short nationally. So that's going to limit testing even with the commercial labs if they don't have those materials available. So that's one issue. So they're looking at alternatives like if the medium runs out, the Carey-Blair medium, I think is what they use, they might use sterile saline. That's not approved yet, but they're looking at those alternatives. Also, the lab validation process that I talked about before, these pop-up labs that are coming up, how do we know if they're validated or not? And we're dealing with that right now. Quarantine and isolation, that's initially what we did was active monitoring of exposed people. Now we're doing passive monitoring, and that's going to be relaxed as we go on, but the release from isolation criteria has also changed. Originally it was 2 negative PCRs at least 24 hours apart. Now we're relaxing it to be, CDC has some new guidance out saying you can do 72 hours fever-free after your symptoms are gone, or 7 days after the initiation of symptoms if you have no more symptoms, things like that. So we're putting guidance out about that. And then the personal protective equipment, I'm sorry I didn't spell that out, but PPE issues. The N95 was originally required if you're taking specimens or dealing with any patient that might be COVID-19. Now they've said if you have a surgical mask and a face shield, that's adequate. There have been some shortages of gowns, so they've used some alternatives for those. Another thing that's changed is negative pressure rooms were basically required if you wanted to take specimens. Now they're saying if you can have a closed door exam room, that's adequate because there's so many facilities that don't have enough negative pressure rooms to cycle through a number of people. So a lot of different things are happening. Let's talk real quickly about lab testing. Our state lab is continuing to test. We get same day or next day results, so it's going pretty well with that. But approval is required because we can't test everybody. So that's still a process. We usually discuss it directly with the clinician and make a decision on the spot and then approve or don't approve for specimens to come in. Commercial labs, as I said, have started offering testing. LabCorp saying they have a 3 to 4 day TAT, which is turnaround time for refrigerated or frozen specimens. Quest is 3 to 4 day. ViraCorp is 12 to 18 hours. University of Washington is saying they've got 12 to 18 hours. University of Louisville, I don't know what the turnaround time is, but University of Louisville has been testing, starting off with a research protocol, and now they're testing. And there's a bunch of others coming up soon, so that's moving ahead. One of our hugest issues, I think this is just about my last slide, is our inquiry management. So since this started happening, since we got our first case, we've been overloaded with phone calls coming in. And so we established a public hotline through Poison Control on March 6th. They've had 18,000 calls since March 6th, so in 12 days. And they've had 195 to a 1,114% increase over their usual call volume on those days. The lowest has been 195. The highest was 1,100% higher than normal. We established a clinician call center just for clinicians at the Department for Public Health, KDPH, on the same day. We've had over 1,400 calls just yesterday and over 10,000 since we opened. So we've been fielding upwards of 1,000 to 2,000 calls a day from clinicians in the last few days asking about whether their patients should be tested or not. We also have our State Health Operations Center, our SHOC, and we get ad hoc calls from the public, clinicians, different folks. Sometimes clinics are posting on their door, we're closed because we don't want to be exposed to COVID-19. Please call this number. They give the SHOC number, so there are people calling right in our operations center. Sometimes it's a real problem. There's also the governor's press conferences. You've probably seen him daily get up and talk a lot about this. Often he knows information before we do because he's got other sources. Sometimes he's heard about a case somewhere that we haven't even heard about yet, and it may not even have been reported yet. So that's one of our ongoing issues, is how to keep up with that kind of stuff. And then we have a website, the kycovid19.ky.gov, and I want to end with that to just show you there's a really good website we've got up now. It's amazing what a crisis could do because we've had struggles for years to get websites up, and this COVID-19 happened and the governor spoke and we were able to get a website up. So got a lot of good information on there for clinicians, for patients, for the general public. Has our hotline number, all that kind of stuff. I'm going to zip through this because we're late on time here. I know we're already after 1 o'clock. We have guides for clinicians, and then there's our hotline number. And we can distribute these slides to you afterwards through Dr. McKinney, I think, so you can have a copy of the slides if you want. And there's the website, kycovid19.ky.gov. That's your one-stop shop for information from Kentucky. And it links to CDC websites as well and stuff. So I'm sure most of you have seen this because it's been around, but I just wanted to share this with you. The World Health Organization has announced that dogs cannot contract COVID-19. Dogs previously held in quarantine can now be released. To be clear, WHO, WHO, let the dogs out. So that's the end of my presentation. I've got a bunch of phone numbers on the last slide here for you, and I'm happy to take questions. I don't know if we have time or capability of doing that, but we'll do our best. So I'm not sure how we orchestrate this, but we'll see. I just don't know how we're going to get the questions.
I can read you some off that I have.
Oh, you got some questions coming? Okay, great.
One question said, did I understand you correctly that ski resorts in Colorado in general are potential areas for exposure and recommendation for testing if someone has stayed in one within the last 2 to 3 weeks?
Okay, so that's a great question. So the ski resorts in Colorado are recommended for people to quarantine themselves if they spent time there. Okay, they're not recommended for testing unless they become symptomatic. So remember, we're trying not to test asymptomatic people, but if they did have an exposure there and they are symptomatic, they could potentially be someone who has COVID-19. Apparently, there was widespread exposure in those ski resorts the last couple of weeks.
To clarify, the recommendations for PPE for COVID-19 positive patients is standard mask with face shield in addition to gowns and gloves?
Yes, yeah, that's right.
And should the N95 be reserved for aerosoling procedures like incubation, suctioning?
Okay, so let me be clear. What's recommended is to use the N95. Because N95s are becoming short, it's an acceptable alternative to use the surgical mask with a face shield with gowns and gloves. So if you have N95s, you got ample stock, that's what you should be using. If you don't, then yes, the N95s will be recommended for those high-risk procedures, surgical mask and face shield otherwise.
Another question, is it best practice to reuse N95 masks between patient rooms, which is what has been implemented in ULH?
Okay, so that's not best practice. That is an acceptable alternative if things are becoming short. The problem with reusing as opposed to continuing use is if you're taking it on and off, your hands are going on and off the mask and you're exposing that mask to pathogens every time you touch it. So that's not optimal. If N95s are in short supply and we need them, or surgical masks, then there are some alternatives. I'm not the expert in that, but I know there are some alternatives out there. I think some of that's on our website to explain what those possibilities are.
Oh, another question is I have heard some patients have gastrointestinal symptoms. Are these common presentations?
I don't think they're common presentations, but we have definitely heard about some patients having gastrointestinal symptoms. So that is happening in some cases. It's limited. I'm just throwing this out there because this is completely Doug Thoroughman, not fact. But I think we're probably seeing around 5, maybe 10% of people have gastrointestinal symptoms. Probably lower than that, but it's not a lot, but it's some, yeah.
It seems like healthcare facilities are responding differently. Who is giving widespread direction to clinicians?
Well, we have given many widespread directives to clinicians. We've sent out several clinician advisories and alerts with information about what to do. I'm not sure what you're referring to as what's being done differently, but everybody should be, doing the same kind of PPE recommendations and should be handling patients in the same way, if at all possible. But that doesn't always happen.
Data from South Korea showed a high number of younger patients who are asymptomatic carriers. Does Kentucky plan to implement any sort of testing for younger populations?
We're not planning to implement testing for younger populations just because of the limitations in our testing capabilities, but that clearly is possible that's happening. And we, in fact, are talking with CDC. We don't know if it'll come to pass, but we're talking with CDC about having a group of epidemiologists come up and help do some research in some of those areas here in Kentucky. We don't know if that'll happen or not. We're just in the discussion phase right now.
How many days post initial exposure does an infected person become contagious?
Well, that's what we're saying is it could be very soon after you're initially exposed that you could be contagious, because we say someone could be infectious 1 to 2 days before symptoms. The incubation period is 2 to 14 days, so they're probably not infectious for those first couple days after they are exposed, but if they, after that point, they could possibly be infectious and then get symptoms and go on to have their course of illness.
If you are a low risk possible case, but know you've been exposed, but are still asymptomatic, should we continue to bypass testing due to lack of available tests?
If you don't have any symptoms, so I'm not quite clear on that question if you're having symptoms or not. It sounds like a low risk contact to a case. Did they say
it said they're low risk,
but still
and they are asymptomatic.
Yeah, no, if you're asymptomatic, no, I would. There's not a good reason to get tested if you're asymptomatic. You wait and see if you've got symptoms, and then isolate yourself, and then test if that's indicated.
Do we know the sensitivity, specificity, and potential cross-reactivity of the COVID-19 test kits? And are there several different tests, especially with all the new labs coming on board, so that there is a lot of risk of inaccurate results?
I would say there's multiple answers to that question. Sensitivity and specificity are pretty good. I think the sensitivity is like 95%. Specificity I'm not positive about, but I think it's like 90%, I believe. But that's through the CDC emergency use authorization. There's a lot of other labs coming up with their own tests, and so that's where the inaccuracy could come in, where we're not sure how high their sensitivity and specificity are. So I would say to be cautious, to make sure you use reputable labs that are CLIA approved and they've been validated. I'm not sure how you find out if they've been validated or not, because I get offers in my email every day now from labs saying, we can offer you 10,000 tests today. So I'm not sure about those labs, where they're coming from or what they really can offer.
So I believe that the references to healthcare facilities responding differently also refers to cancellation of outpatient clinics and overall clinical operations. Is there any widespread guidance for that?
Wait, read that again. The reference to healthcare facilities responding differently. Oh, yeah. Well, that's we can't really make specific guidance on that. Each facility is going to have to make its own decision, and that is a problem because there are some healthcare providers who are refusing to see patients who have respiratory illness because they're worried that they would bring that into their facility and then they wouldn't have any healthcare workers left. So I'm not quite sure what to say about that, but we don't really have any call on that in public health. We'd like people to stay open and be able to keep seeing patients because that's going to be a critical need in Kentucky. Getting text from all kinds of people.
Yeah. Our time's up, or?
Yeah, I don't know. I see Paul, Dr. McKinney there on the camera. I don't know if you want us to stop answering questions or if you want us to keep going. I see. No. Do you anticipate travel restrictions within the U.S. anytime soon? I don't anticipate travel restrictions. I'll tell you why. Unless an individual state makes those, this country is kind of based on freedom of movement and things like that. So we're trying to implement these social distancing measures, recommending that people isolate themselves if they've got symptoms, things like that. So I don't anticipate they're going to shut down any travel, but I don't know. That's up to the government to make those decisions. So, Paul, if you guys want to text me if you want me to keep going or something, that would be great.
Thank you for doing this. I know there's a lot of unknown right now, but When do you think all this will die down? We've heard you lie. Do you agree?
Well, so there's a good question. When's it going to die down? There's a lot of theories out there. If we do good social distancing and really keep people from being in contact with one another, it could die down rather quickly like it has in China. But they did very strict quarantine measures. They had people basically locked down in their homes. They had a couple hours a day to go out and go shopping, things like that. They had drones flying over to ensure that people were staying in their homes, and they did it in a huge area. So we probably won't be able to do that strict of a quarantine kind of measure. It could fester for quite a while. If it's like other coronaviruses, it might disappear in the springtime, in the summer, because it's a lot of those viruses kind of go away when it gets warm out. It is being seen in South America though, so I wouldn't rule out that it could keep going through the summer here. because they've got warm temperatures there and they're still seeing cases, but those could mostly be imported cases come from other countries. I don't know that yet. So
in primary care, we are seeing some patients. We're seeing some patients with symptoms consistent with COVID-19. If they have a flu test, should we use our commercial lab to test, even if they are considered low risk and do not have a known COVID-19?
yeah, I would use a commercial lab to test those if you can. Yeah. They told us we can sign off, Jody, so I think we'll take that as our last question and go ahead and let y'all go. Thank you so much for attending. I'm sorry for all the technical difficulties, but thank you to those who hung in here and are viewing the webinar. And if you have more questions, you've got the public hotline to call, or you've got people at U of L who know how to get hold of us if they want to contact us. So thank you so much, and I hope you all have a great day.